This week on the Core Ultrasound Image review, I travel all the way down 4 hours from Lexington, Kentucky to Chattanooga, Tennessee, and get to hang out with the one, the only Ben Smith, MD. It was such a nice day that we had to record outside. And as you'll see in the video, there is a little bit of background noise, but I don't think it takes anything away from the amazing educational pearls that Ben drops on us. Check it out and let me know what you think. Ben Smith.
Jacob Oswald.
Dude, it's so good to see you.
Good to see you too.
We are in Chattanooga, Tennessee. I'm just enjoying the sunshine here. And we were able to get you, Dr. Ben Smith. He has a obviously very busy schedule, but he was nice enough to sit down with us to go through some image reviews. Now, this is like super important for me because Ben was my ultrasound director when I was a resident. So it's really cool to sit down and do this as like adults. Well, you were an adult when I was a resident, but like that, we're both adults now. So it's like exciting.
That's right. Yeah, we did a ton of image review when we were back in the day.
Yeah. So it's nice to kind of like go back and reconnect, I guess.
That's right. Yeah.
Shall we go over some images here?
Yeah, let's take a look. We'll see what you can.
Sweet. All right. So the first image, don't look at this down here, by the way. Just forget about this. What are you seeing here?
It looks like a soft tissue ultrasound. I can't really, sort of differentiate subcu fat from, I don't know if that's muscle or tendon. I'm not sure exactly where this is.
You're talking about like down here? Like
Yeah,
this area
exactly.
Here? Yeah.
I really can't tell exactly what I'm looking at.
Yeah.
Like, it's really kind of all blurred together.
Yeah. So this, I mean, it is labeled appropriately cellulitis, and this is something that I actually learned recently. Now, classically with cellulitis, we learn cobblestoning, right? We learn that we're supposed to have the little like pockets of soft tissue with the fluid in between it. However, it turns out that in the earlier phases, you basically just have a distortion of the architecture, which is really what we're seeing right here. We're seeing all of this right here is the subcutaneous tissue, and I'm not seeing like really good definition. It's very blurry. This is also what cellulitis looks like. And the resident who saw this was a great resident. He's no longer a resident with us. He is an attending now. Did a great job with this, and he labeled it appropriately as cellulitis, even though it wasn't cobblestoning, the classic cobblestoning. So I thought it was a good one to share.
That's cool. I will also say that, when you do see cobblestoning, you can see it just with any patient that has third spacing of fluid in the subcutaneous tissues.
Such a good point.
So actually, if you have a great time to see amazing cobblestoning, you have a CHF patient with edema in their legs, just throw the ultrasound on their legs. It looks just like classic cobblestoning. So it's a clinical context thing. Like, I put this on the skin where it's red.
Yeah.
And maybe a little indurated, that's cellulitis.
Gotcha.
With cobblestoning. But if you put it on a leg, this edematous, because they've got CHF, it's probably just edema.
So are you saying that we need to clinically correlate our ultrasound images?
I am saying that. So this image is not pathognomonic for cellulitis, but,
you're right.
but if you applied this test to the correct patient, this is consistent with cellulitis.
Brilliant. And I couldn't agree more. I mean, the more that I do ultrasound image review, the more when I look at an image, I'm like, well, it could be one of these 5 things, especially with like whatever, scattered, like focal B lines, for instance. Like that, there could be literally 10 things that could be depending on how the patient's presenting. So I have a lot more kind of respect for that. And one thing that I think you taught me, I'm sure you taught me this, is that ultrasound should never be used in isolation. It's never like the ultrasound by itself. You got to take the whole patient, and you add the ultrasound as like a data point to kind of help you diagnose what's going on with your patient.
That's right. Sort of moving the needle on your pretest probability. You're applying the test, which is ultrasound, and then sort of pushing the needle to your post-test probability. And in jest, we kind of make fun of radiology when they say clinically correlate, but it really is.
It actually matters.
Point.
Yeah, agreed. The next one is something that I am excited to learn a little bit more about, and that is this right here. Ben, what do we see here?
So this looks like they're using the linear transducer because it's a flat on the top. So it's a high-frequency probe.
Nice.
I'm guessing that they're using a water bath, the way the structure is kind of like moving up and down.
You're talking about like kind of up here, this like black space?
Exactly. There's no way that's gel. That's got to be a water bath.
Yeah.
And it's probably a digit, either a finger or a toe. I can see structures really well. There's some fluid inside that finger. Or
you're talking about like right here?
Yeah.
It is a finger, by the way.
There is some fluid there, and it's adjacent to the tendon.
Here?
Yeah. So, tenosynovitis is kind of on the differential there for sure.
Yeah, I agree with you. Now, right, if you look at right here, this is actually a joint. It's not a fracture; it's a joint. So this is like actually flexor tenosynovitis right here.
So it's on the flexor side on this finger.
It is on the flexor side, and you can see that that fluid is completely surrounding the tendon. Now, I'm going to be real with you as far as like my own limitations. I don't know very well the literature behind this, but I don't know what else this could be except for fluid around the tendon sheath. I mean, it's literally above and below the tendon. It's got to be fluid within the tendon sheath, and of course, if the patient has a swollen digit, it's probably flexor tenosynovitis.
That's right.
I worded that wrong.
Like, yeah, tenor.
Actually,
It's the base tenosynovitis. The base device. Anyway, so I think that in the past I've used this like I have a patient that I think might have it.
Yeah.
And then I look, and if I see the fluid, that it kind of seals the deal for me. But it doesn't rule it out if it's not there, sort of thing. They've got 4 to 4 canable signs, very suggestive.
Right.
And then if I go to look, at that point, if I don't see it, I'm going to probably still get a hand surgery consult, thinking they may have it. So.
Yeah.
And again, I don't know. I don't know if there actually has been a large series published on this.
I don't know either. I need to learn about it, to be honest. It's like on my list of things to like learn more about. But in the meantime, I'm pretty sure that this is soprano. Tenosynovitis. That's right. Okay. Keeping in line with the soft tissue ultrasound theme of the last few images, let's talk about this one. Now, let me give you a little bit of a context here. This guy right here, this is this muscle right here. That's the sternocleidomastoid muscle. Down here, we have probably the levator scapular muscle. What do you see here that's weird?
Well, inside the sternocleidomastoid, there's a hyperechoic structure with a shadow behind it. I'd love to hear the story on this fella.
He fell through a glass window.
Huh. Was this a bar fight involving a glass bottle? Like, I could see that.
Yeah.
The glass bottle broken off. Hit him in the neck. Yeah.
Actually, what I was thinking more was like the classic Western, like they open the saloon doors that are like, they swing in, you know what I mean? And then like they come in, all the music stops.
Right.
And then there's like just a brawl. It was like how I was picturing it.
And someone gets thrown through the window.
And someone gets thrown through the window. The window happens to shatter really easily, by the way. And then they end up with this. This is glass in the neck. Now, when I initially saw this, I kind of had a hard time identifying the type of foreign body it was. Do you have any idea if there's a way we can tell the difference between like wood and glass and metal?
Metal tends to give you that reverberation artifact.
Okay.
Or I guess people call it a ring down artifact.
Right.
Like
But it is a reverberation artifact, though. Like the ring down artifact is a reverberation artifact.
Exactly. And everyone's used to seeing that when they're looking at, for instance, a really, intense looking needle, like when you're doing a, ultrasound guided IV. Sometimes you can see that very same ring down artifact. And then differentiating like glass. Actually, I have to say I have seen that ring artifact sometimes in very like linear flat pieces of glass where you've got two surfaces where it actually will reflect back and forth. This looks like a really irregular piece with a shadow behind it, so I don't see that ring down artifact. Like, I think this would look really similar to just having a wood fragment in your neck on ultrasound.
And I don't think that I can tell the difference, to be honest. I can tell a foreign body, and I will say that like wood, I have seen it shadow a bit like this glass does. I've seen glass shadow, and I've even seen metal shadow sometimes. So I think that telling the difference between them is pretty difficult. And again, clinical context matters, right? Like, what did the patient go through before they got to you would kind of help.
Right.
Yeah, this is it's kind of like a side note. I'm wondering, and I didn't see this patient. This is on the image review from the images done at where I work, which is the University of Kentucky. But I'm wondering, it's really close to where the superficial cervical plexus comes out of in the neck. So I'm wondering
that same thing.
Yeah, I'm wondering like there was any. I mean, because of that, I rarely, if things are not causing too much issues, I rarely will go digging and try and remove something like this. But I'm wondering, like long term, like would this guy have any like deficits because it's so close?
Yeah, and it's pretty superficial. It's just 1 centimeter underneath there.
Yeah.
In general, I try not to put a knife on the neck. But
fair enough.
Exactly. But yeah, it's an interesting thought. If you went to like numb up around this foreign body, you'd end up with like good anesthesia, and you could put central line in.
That's right. That's right.
He also broke his clavicle in the
And it would be
so
good.
that's right.
And also he has his ear is lacerated.
That's right.
His ear
Yep.
right there.
Yep.
And we say that because all of that area gets blocked by blocking the superficial cervical plexus, which is like an amazing block. It's like one of our, I mean, I don't know, I want to speak for you, but it's one of my favorite blocks to do because I think
It's
that's such
easy.
a good job. It's
Yeah.
easy. It's easy. All right, let's move on to my favorite topic, which is lung ultrasound. This is a crazy lung. You see the respiratory rate is like super high, right? I mean, this is the diaphragm right here. We have either, this is probably spleen, but it could be liver. What do you see, Ben? What's going on?
So I can see above the diaphragm, I can see a lot of
Right up here.
like middle echogenic, what looks like fluid movement there, and I can see the lung as well. Probably atelectasis of that lung down
Down
there.
here?
Yeah.
Yeah.
And so, in clinical context matters, but that's kind of a plankton sign because you're seeing that little
What is that?
plankton sign. It's like little particulate matter floating inside that pleural effusion.
Yeah, so that means if you got particulate matter, I mean, that makes it much more likely that it was an exudative effusion rather than transudative.
Yep.
I haven't seen a whole lot of data with how accurate the plankton sign is. It's more kind of like an anecdotal type thing from my experience. Have you seen anything that says like, you know, the accuracy of plankton sign is X?
Right. No, I haven't. But I will say that I've looked with a curvilinear probe before, and it looked almost totally anechoic, and then switched to the phased, and it almost started to look like a plankton. Yeah. And you can also like ramp up the gain to get those little echoes to show up in there. So from personal experience, I don't feel like it's really super specific.
Yeah, I agree. I think it's something that, like, if I see this and the patient has like a fever, I'm like, oh, that's, you know, an exudative effusion, probably, you know, empyema or a complex, what do you call it? A pneumonic effusion. But yeah, I'm not saying that to like diagnose it and be like, done. I don't even need to see the patient. It's this, of course.
Yeah, certainly suggested though.
This is like one of my favorite clips that I took a few months ago. It's insane. Can I give you the clinical context of this patient?
Please.
Obviously, there's a lot of movement. This patient was in a fair bit of distress, had a gunshot wound to the right kind of like flank area.
And where's the probe exactly?
It is mid-axillary line, probe marker facing up, right at about the inner nip line.
So on the right image,
This one over here.
yeah, we've got what looks like a liver type parenchyma right
Over
there.
here?
Yeah, it looks like sort of a typical echogenic appearance of liver. And so I would expect that structure just to the left of that and above it is going to be, just like right there. It's gonna be diaphragm.
Oh, this thing right here.
Yep.
This the
diaphragm.
kind of border right here around the liver.
Yep.
Right there. Okay.
And then above that, I'm seeing I'm seeing what looks definitely not like lung because I'm seeing the spine continuing underneath that. So it's not as being transmitted all the way through there.
Talking about this right here.
Yeah, and exactly. And then posterior to that, I can see the spine continuing.
here.
So it's positive spine sign.
You know, it's interesting that you say that because you're obviously better than me, but when I first saw this, I was like, oh, those are air bronchograms. That's lung. When I first saw this. But you were right. This is actually not lung.
Yeah, it certainly could be. I don't know what it is. I know that it's transmitting the sound. So it's either densely consolidated lung, or you said it was a trauma patient. So, could it be blood or pulmonary, hemorrhage?
Yeah.
All those things are kind of in the differential, I think.
So what I think that this is we have more hypoechoic fluid up here, and I believe that all of this right here is actually clot.
Huh.
It was way too goopy for it to be like a lung. There wasn't a discrete kind of container in which that structure was located, which is how the lung is.
Yep.
So for me, and then I don't know if I have it on these clips, but you see all of this over here, and then there's another structure kind of, they're not connected. They're very like goopy.
Right.
And then further up, I was able to see a structure that looked a lot more like the actual lung.
Yeah.
So this didn't necessarily like change management, knowing that it was clot versus lung. And honestly, it could still be like just a messed up lung, to be perfectly honest. But this is basically to show this patient had a hemothorax due to the gunshot wound.
Can we freeze it like right there?
Freeze it where you want, man. Where do you want to freeze it? Here, go ahead.
It's kind of like, I want to point out something here that's just a kind of interesting this is a really common artifact you see. If you have the ultrasound beam coming in and it sort of hits the tangent of the diaphragm here, sort of that interface between the diaphragm, the liver, and then above the diaphragm, you get this shadow right there. It's really common and so whenever you're, for instance, looking at the gallbladder for a stone, for instance, you'll see that same shadow come off as the ultrasound beam hits the tangent off the edge of the gallbladder.
The good old edge artifact.
Yep.
Yeah, I think that's there's two. You mentioned the gallbladder to make sure that you don't think that that's stone with shadowing. That's a really good one. The other one that I see is in the left upper quadrant. Sometimes you'll see that, and when it shadows, let's say that this is the left upper quadrant. All this is fine up here. I mean, that's where a fast would be positive in the left upper quadrant, right in that area. The difference is that a positive fast would kind of curve, whereas this is just a straight line down, which doesn't make sense anatomically.
Right. That's a good point.
Sick. Ben?
Yes.
Thank you so much, man. This is great.
Yeah. Thanks for coming by.
Yeah, no, this is great.
I think it's been like 6 months since I've seen you, maybe even longer. Actually.
Yeah, it's awful. We've seen each other via the FaceTimes, but not in real life, which this is much better. So hopefully that was helpful for you guys. Stand by next week. We'll have Ben Smith for another ultrasound image review, and hopefully hear from you soon. I hope you enjoyed that as much as I did. Now, with cellulitis, remember that early on, patients with cellulitis might not have the classic cobblestoning that we're used to teaching about, used to seeing. Sometimes you just have a bit of distortion of architecture. If you're not sure, look at that area of the soft tissue and compare it to an area that is unaffected and see if there's any difference. If there's a difference, likely to be an early cellulitis. As far as foreign bodies underneath the skin, anytime that you see any kind of irregular or regular, depending on what the material is, hyperechoic rim with some shadowing underneath it, consider that that is a foreign body. You can't really tell the difference between different types of material reliably, but it doesn't really matter. It's just identifying that foreign body. With regards to the plankton sign, that is thought to be specific for an exudative effusion, although there is no really good data that looks at the sensitivity and specificity of that for ruling in or ruling out a transudative effusion. So just kind of something to think about. And as far as clot, remember that clot in the thorax, or to be honest, even in the peritoneum, often can have a bit of a more hyperechoic structure to it that you might confuse for an organ. So just be careful with that and make sure that you clinically correlate. Hopefully that was helpful for you guys. I'm looking forward to hearing your questions and comments, and happy scanning.